Welcome to this screencast about the Microskills of Teaching, which aims to enhance the teaching skills of medical school faculty. I am Ron Sizo at the University of Oklahoma School of Community Medicine. My academic positions include Professor of Medicine and Associate Dean for Academic Programs. This presentation focuses on specific skills of teaching, adapted from the 5 microskills of clinical teaching, also known as the 1-minute preceptor. First developed in the early 1990s by Nair in Seattle, the microskills have been validated in numerous studies to enhance skills acquisition and improve teaching efficiency. We have made revisions attempting to enhance the teaching components of direct observation and feedback. In 1983, Jack Indy wrote a seminal article on the role of feedback in medical education, which remains a must-read for medical education faculty. Dr. Indy made the following statements. Without feedback, mistakes go uncorrected, good performance is not reinforced, and clinical competence is achieved empirically or not at all. Feedback occurs when a learner is offered insight into what he or she actually did, as well as the consequences of his or her actions. This insight is valuable insofar as it highlights the dissonance between the intended result and the actual result, thereby providing impetus for change. The processes of learning and evaluation may be depicted by 2 interconnected circles that we call the education bicycle. In the lower circle, learning begins when the learner performs a task, such as taking a history. Direct observation of the learner in action is required in order to provide effective feedback. The learner incorporates the feedback, then attempts to adjust performance by practicing the task again under direct observation, receiving feedback, making adjustments, and trying it again. This cycle is the formative process of performance improvement. The upper circle applies a test to the student's performance, which allows a judgment on the performance measured against the expectations set out in the course or performance goals. This cycle is the summative process that documents achievement. The education bicycle demonstrates the critical role for explicit goals and expectations, which are necessary for evaluation, and direct observation of the learner's performance, which allows meaningful feedback. We have adapted the 1-minute preceptor to create these microskills of teaching, which are establish learning goals, get a commitment to an interpretation of the data, probe for evidence supporting that interpretation, provide feedback by reinforcing what was done right, correcting mistakes, and attending to emotional responses. Teach general rules. Encourage reflection and integration by prompting self-assessment of performance, stimulating self-correcting commitment to change, and inviting feedback on yourself as the teacher. I'll now describe these microskills in more detail. At the beginning of a teaching encounter, the teacher establishes explicit expectations for the session, preferably incorporating learning goals of the student. Clarity of expectations allows focus for your teaching and communicates to the student the areas requiring their attention. Specificity of expectations is more helpful than generalities. For example, helpful statements for establishing goals might sound something like, "What would you like to accomplish today? I'd like you to focus on an organized and complete history and report back to me in 15 minutes. Non-helpful examples might include, "Go see this next patient and tell me what you think." The next microskill is get a commitment to an interpretation of the data. Early into the encounter with the student, the instructor should prompt the student for a commitment to a diagnosis, workup, or plan. By making a commitment, the student feels responsible for patient care and enjoys a more collaborative role in problem solving. Making a commitment encourages the student to process information collected during the patient encounter, which promotes elaboration of knowledge by connecting memorized data elements with clinical situations and helps identify knowledge gaps. Failure to commit to a formulation of the data indicates that the student has not processed information, is reluctant to expose a weakness, or is dependent on the thinking of others. The cue for this microskill occurs when the learner presents the facts of a case and then stops, waiting for the instructor to offer an interpretation. At this point, you need only resist the urge to fill in the verbal blank and instead ask the student what they think about the data just presented. Examples of ways to get a commitment include, what do you think is going on with this patient and why? Or, what other data would you like to know? Offering your own diagnostic considerations suppresses the student's knowledge processing, as this tends to lead the student through your thought processes rather than exposing the problem-solving processes of the student. The next microskill is probe for supporting evidence. Once the student makes a commitment, you can help her reflect upon the mental processes used to arrive at that decision. The cue to this microskill comes when the student commits to a particular position and looks to you for confirmation. Suppress the desire to pass judgment, but instead ask the student what evidence supports this commitment. An alternative method is to ask what other choices were considered and what evidence supported or refuted these alternatives. By probing for supporting evidence, students reflect upon their reasoning process and articulate it out loud. This allows targeted instruction and correction of any errors in data synthesis or interpretation. Strategies to probe for supporting evidence include, what findings led to your conclusion, or what else did you consider? This step urges students to think out loud, which can be suppressed by premature judgment of right versus wrong. Likewise, switching to Socratic questioning can inhibit students risking exposure of their thinking processes. The next microskill begins the feedback process by telling them what they did right. Some appropriate actions are pure luck, others are more deliberate. Without specific feedback, the student may not realize the effectiveness of their action. To become firmly established, competencies must be repeatedly rewarded in some fashion. It is important to realize that this microskill is not general praise, which serves to reinforce no particular behavior. By telling a student that they did a good job does not reinforce why the job was good or map out a way that the job could be done better. Both praise and criticism need to be as specific as possible. The next component of feedback is to correct mistakes. Correcting mistakes was placed near the end because it is the nature of many to put this microskill first. Correcting mistakes is essential, but it is only one part of the teaching encounter, and it requires tact to be effective. First, an appropriate time and place must be chosen. While it is best to give both positive and negative feedback as soon as possible after an event, the sensitivity of the situation could require that this microskill wait until a calmer, more private setting can be arranged. Second, it is generally a good idea to ask the student to critique their own performance first. Medical trainees are often highly self-critical and will tend to self-identify mistakes made, which allows acknowledgement by you along with recommendations to avoid similar errors in the future. When not recognized by the student, you can provide your observations and suggestions for future action. Be specific in describing the error. Vague judgments are not helpful. Remember, mistakes left unattended are likely to be repeated. An example of specific feedback regarding selections of medications might be something like, while your diagnosis is correct, you chose an expensive medication when cheaper and equally effective choices are available. Here's another example. You could be right about the child's symptoms being due to a viral upper respiratory tract infection, but without examining the ears, you could easily overlook an otitis media. The OU curriculum instructs students to identify the primary emotion of the patient. The same is true of learners. Students often fall short of their own expectations and fear loss of respect from their instructors. Embarrassment is common. Recognizing this, the observant instructor watches for the facial blush, the sweating brow, or emotion-laden words. Identification of the emotion invites the learner to speak about their response and allows the instructor to empathize and normalize as common in similar situations. Unattended, the emotions may interfere with subsequent learning. Using reflective statements such as, "I can see that you're disappointed," or "You seem upset by this feedback," communicates to the learner that you've noticed an emotional response and invites their further comment. Avoid minimizing or ignoring the emotion, which, when effectively attended, creates the buy-in for performance improvement. The next microskill is teach general rules. From what the student has revealed, teaching points will be apparent from any gaps or mistakes in data, knowledge, or missed connections. Instruction is most memorable and more transferable to other cases when framed as a general rule. General rules are often stated as standardized approaches to similar encountered. General rules usually follow the format of when X happens, do Y. For example, regarding a young, healthy adult presenting with low back pain, a general rule about imaging might be, if a young, otherwise healthy adult has mechanical low back pain, then X-rays are usually not needed, except in specific instances. By using this if-then model, the guidance can be transferred to other cases of low back pain. In adults, enduring learning takes place by a synergistic process of reflecting on experiences and melding them with previous knowledge and beliefs. Taking time to debrief on the day's cases or teaching encounters enables the learner to do some critical thinking and analysis. By encouraging the learner to articulate what did not make sense or what made me uneasy each day, the instructor can provide direct teaching or indicate appropriate areas of study for the learner. This reflecting and integrating process also provides opportunities again to reinforce positives from the prior experiences and can guide the planning of future learning, including the resetting of goals. The process is best initiated by open-ended questions such as, how did things go today from your perspective? How is the experience different from your expectations? Did anything surprise you today? To summarize, the microskills of teaching are establish goals by asking, what would you like to accomplish in addition to the goals I've mentioned? Get a commitment by asking, what do you think explains the patient's problem? Probe for supporting evidence by asking what leads you to that conclusion or what else did you consider? Provide feedback, first by reinforcing what was done right, by stating specifically, you did a good job of X because I saw you do Y. Correcting mistakes by saying, the next time this happens, what exactly will you do? And attending to emotional responses by stating something like, you look a little upset about your performance. Teach general rules by saying, when X happens, do Y. And finally, encourage reflection and integration by asking, how do you think you did today? What will you do differently next time? And what did I do that you found helpful? These steps comprise our recommended teaching behaviors, which can be used all together or a few at a time. They address a student's database and cognitive processes, guides appropriate teaching, and implements immediate specific feedback. For instructors, the model will likely increase efficiency and effectiveness of teaching. Compared to traditional precepting, the model does not prolong the teaching time, and the instructor feels more confident in diagnosing patients and evaluating learners. Usage of this model also encourages instructors to provide more specific feedback and motivates their learners to continue learning by doing outside reading. We encourage you to incorporate the microskills of teaching into your personal set of teaching tools. Thank you for your attention and interest.